Bom dia, tudo bem? Good. One of the things I particularly enjoy about coming to international events is so we can share our experiences. So what I'd like to do today is share my experience. So I'm going to talk to you about our experience of developing standard indicators that underpin good quality care. I have many years working as a researcher, looking at our health service and wondering how we can support the health service to get better. Then I became a manager, a national manager in the health service, thinking about how we can get things better. So what I'd like to do is share with you our experiences, and then I would love to hear your experiences, because I believe that we could learn from you as well. Okay? We develop standards and indicators, and we do this for a number of reasons, and it's not just because it's government policy. We do it because we believe it's the right thing to do. And I've put this quote up here because I think this really underpins the importance of indicators, because how do we monitor healthcare quality if we don't have something to pin that on? And in Scotland, we have a range of indicators and standards that look at all sorts of services: pregnancy and newborn screening, cancer services, healthcare acquired infection, post-mortem. So we have a real range of services that we provide that have indicators underpinning them. Because without that, how do we know what we're doing well? And how do we know where we can share what we do well? But equally, how do we know what to change? So why? Why do we have a whole system of indicators? We have lots of reasons. And the first one is because it documents our quality of care. It tells us where we are, it tells us what we're doing, and it tells us where we need to go. Because without that document of care, too much of our information is anecdotal, and it's then hard to ensure that we have a reliable system that is equally accessible to all. And it's really, really important for us to know where we are now. So we document the quality of care. And we have found that when we document this quality of care, it can support improvement, because we understand what we do well, but we also understand areas where we don't do so well and we have to improve. Because for every patient, every time, we have to have that same high quality. And in Scotland, we have an enormous improvement programme that specifically looks at spreading high quality care across the whole of the country. We have found that by adopting indicators, we have increased our transparency. And we know that organisations that have indicators replicate that. Because what we do, we share. We know what we do, and we share it, and we learn from it. And without that documentation, how do we share something that's based on evidence and on recognised practice? So it's really, really important. If you are committed to a transparent system, you have to think about how you're going to capture that information. But we also use indicators to support accountability. And I don't just mean accountability to those that pay for the service or commission the service. I also mean accountability with our peers, accountability with our patients, and accountability with our planners. Because without that transparency, how do we have accountability? And I know from discussing with some of my Brazilian colleagues that actually accountability is a real key. It's a real key issue. And we have that accountability to the point that we have public meetings where our data is interrogated by members of the public, because we really understand and value the importance of accountability. But it's also really important in terms of regulating services and accrediting services. And I've heard from some today and some yesterday when we were discussing about the top hospitals. How do we know which are our top hospitals, which are our top services? Do we accredit everyone, or do we only accredit those that perform well and that can demonstrate that they're performing well? But we also have indicators that support planning. So we know where our seasonal trends are. We know what the current healthcare problems are, and so that we can plan services accordingly. And in the UK, we have tremendous health pressures around winter time. Without having those indicators to identify what the pressure points are, we are unable to plan effectively, and we are unable to deliver safe service. But also in terms of supporting planning, if we know the kind of services that people need and that are effective, then we can target services and we can minimise variability. And these are other key factors. Another key issue that we have found is that it enables us to make comparisons, not just so that we can benchmark our services, but that's really, really helpful because it helps us identify trends like the winter problems that I've described. But it helps us look at how we compare to other services. So, for example, if we have a service that's doing very well, or a service that's doing not so well, by having this data, we're able to make comparisons and unpick if those variations are to do with a system, a process, or an outcome. But it also allows us, both as clinicians and as service providers, to make judgments. What is the most safe and effective treatment? How do we do that if we don't have the indicators to help us inform those decision-making as clinicians? But it also helps us determine where we should refer people to, what kind of treatment they may wish. And not just clinicians. For many of you, and I understand that in the UK we have very much a predominantly public healthcare system, but actually it also informs patient choice. Now, in the UK, that patient choice isn't necessarily about which hospital or clinician to go to. It is more about the treatment and the intervention. But regardless whether it's a private sector or public healthcare sector, whether it's insurance, where it's universal, it supports patient choice. And we have found that patients are far more empowered to make decision-making. The internet alone has equipped patients with a whole range of expectations about medications and treatment. And so we need to meet that expectation and be prepared for that expectation. Finally, I just want to mention about the importance of indicators for research. And Renato has presented a great number of very helpful and informative slides around the research. But indicators inform that research. And we have in Scotland a small population, and we are working across Europe and Australia looking at the indicators that we have about rare diseases so that we can develop best practice. Because we recognise that actually collaboration is a real key. And if we don't collect indicators, we cannot be involved in that discussion round the table, as well as those of our colleagues who have collected that data and who have analysed that data. And many of us in our professional lives are also researchers. Many of you will be looking at your patient data and be writing papers. And again, the rigours of paper publication requires us to have robust systems of developing quality indicators. So there's a whole range of reasons why we should develop indicators, have data, report, all these things. And for me, some of these, as I've described here, but actually it's because, for me, collecting data on what we do and what we do well is actually the right thing to do. And it shouldn't just be because we need to be accountable. It shouldn't just be because we need to report that to our commissioners of our service. It's because it helps us reflect on our own professional conduct and our own professional practices. And so that when we support others, we are doing that from a very informed position. So we're not just talking about safety, we're not just talking about clinical indicators, but we're talking about reflective practice. And for these reasons, I think it's really, really important that we develop indicators. And I'm sensing your commitment, by the fact you're here today, you're also committed to the development of indicators. So what about the international experience of indicator development? Over the last 15 or so years, there has been a real expanse in the use of indicators across the world. It is varied, it is patchy. Some aspects of healthcare do this routinely. It's as big a part of clinical practice as hands-on treatment to the patient. But in other areas, it's less so. But there seems to be this universal commitment to developing indicators and to recognising the value of indicator development for both the organisation, for the people who deliver the services, for the people who use the services. So this has been a huge increase in activity. One of the things that struck me, though, is who mandates indicator development? And in the UK and in much of Europe, the mandate comes from the government or the parliament. But not always exclusively. So we know of countries where it's a partnership. It's part of the negotiation of the provision of care with an insurance or another care provider, be that private or public. Because one of the keys is if it's not mandated, it tends to be less likely to happen. So across Europe, we see instances where that may be supported by a private institution, for example in Germany. It may be that it's part of the negotiation of the provision from the insurance company as it is in Israel. But the mandating of the indicators is often driven most strongly and passionately when there is a government directive. But there's one thing to develop an indicator. There's quite another thing to use the indicator for quality improvement. And I've seen many, many global examples where indicators are used, and there's very good data about patients, about demographics, about mortality rates, but far less is there done about quality improvement. And I wonder how many people in the room today participate in audits and audit cycles. And of those, how many would use that data to actually look at how they improve services, not just within their own sphere, but actually sharing that intelligence with others? And often we do that in publications, but we're less likely to do that with other organisations, particularly in a predominantly private provision of healthcare, where there is more of a competitive edge. So I would just ask colleagues to really reflect and think about not just having indicators and not just having the data, but about that meaningful and active development into quality improvement. And that varies internationally significantly. One of the other things is in terms of the scope of indicators. And again, globally, we see trends that indicators are much more likely to be based on acute provision of services, far less in primary care, and even less in community-based care. For some countries, prisoner healthcare is also provided by public healthcare. And again, when we look at the scope of settings and sectors, we might find that that kind of data is shared and published by the prison service, but less so by the health service. But certainly, across Europe and in other aspects of the world, for example, Australia and New Zealand, we are seeing a broader sweep for indicators to be across from acute to all sorts of other sectors, because we recognise that people have far more complex health conditions, and if we just look at the acute setting, we will be unaware of how that may play out when they return to their community. The purpose of indicators globally is varied. For some, it's around performance pay. That is less the experience in Europe, and France is one of the few countries which is experimenting with performance-related pay based on indicators, and I understand in other parts of the world that's much more a motivation to have an indicator. But there are lots of reasons why we have indicators, and I mentioned in the earlier slide around planning, around minimising variation, around ensuring that the healthcare that we deliver is safe, ensuring that healthcare is equitable, but it also may be around research. And certainly there is a huge move within the global community to look at indicators and about how we collaborate and we make comparisons, not just in our methodological aspects, but also in clinical aspects. So, for example, in congenital heart disease, significant amount of indicators around congenital heart disease, around survival rates, and around treatment. And the purpose of the indicator there is not just to support the person who's receiving care, but actually to develop a community of interest and expertise. In terms of data collection, analysis and reporting, again, great variety. Most data collection that happens internationally will be done electronically, and most will be routine data. But we're also aware that there are pockets where that's observational data as well, and certainly in the UK, we have, when we look at data collection and we do inspections of hospitals, for example, for healthcare acquired infection, We have significant amounts of observational data. But there's also an awful lot more data being collected about people's experience of healthcare, about their own self-reported outcomes of healthcare. And that presents those who are particularly interested in robust, reliable and valid data sources really question it, because how can we make observational data as scientifically robust as a validated tool? But there's real difference as well in terms of analysis and what we do for minimizing risk. What do we do about false positives? What do we do about false negatives? And how do we standardize data so that we can, if the purpose is to look at national data, how do we ensure that we actually reflect that in the way that we analyse the data? But one of the biggest differences is reporting. And in the UK, we report almost everything. The only data we do not report is where we would identify a patient or a clinical group, a very small clinical group. Otherwise, we publish everything. But we know in lots of other countries, data is not published in that totality. We know that only pockets of data will be published, and they will only be published either for government or for the provider. But very rarely have we seen in other parts of the world the volume of data that the UK publishes. And we also publish everything online, and it's all in a variety of formats and languages. So that's at one end of the continuum for data publishing. But we recognise, and I'm aware from speaking with some Brazilian colleagues, that actually that is not universal. Finally, just to say around comparisons and collaborations. How many people here collaborate internationally? Some hands up? I'm sure you do. I can see a few hands. How many people look at other countries' data and compare them to your own? So we work in a global community, particularly those of us who work in very specialist fields, whether it's healthcare, acquired infection, or it could be the cardiac that I mentioned earlier. So we use other people's data often to reflect on our own, and other people will use our data. And as we go forward, there will be a greater expectation from our international colleagues that the indicators that we have, we will develop, we will refine, and we will share. And that seems to be a universal movement. There's an expectation that more and more providers will share more and more of their data. So that's what we found. I was fortunate enough to be involved in a European-wide research project which is just about to be published. And one of the things that struck us was how many things we have in common. And where we didn't have things in common, where we published things differently, why don't we publish everything? Or why do you publish everything? And these are the kind of conversations that I would really ask you to think about. And to really ask of yourself, of when you're talking about your own indicators, to reflect on your own practice and to think how maybe some changes to those practices will really affect the way that you interact with your colleagues and with your patients. Because we have found that that's made a huge difference. So when patients come to us, and because there is a level of expectation about accountability, we have a different dialogue. Okay, so the UK experience, many of you will be very familiar with aspects of the UK health system. We have a public health sector which is almost 70 years old, and every patient every time should receive the same high quality of care. In the last 15 years, that was devolved to each home country, represented by the different colours on the map. So the government in each home country has responsibility for the delivery of that healthcare. And things are being done quite differently across the UK. In England, there's far more privatisation of healthcare. In Scotland, it's much more about public healthcare. All of our standards and indicators are evidence-based. We look at the evidence. If there is a lack of evidence in any particular area, we go by expert panels and we go for a consensus model. Whenever we develop standards and indicators, we have members of the government there. We have clinicians, we have planners, we have inspectors, we have improvement advisors, we have researchers, many, many ranges of clinicians, but we also have patients around the table when we develop our standards and indicators, and it's an absolute key aspect of our work. A lot of our standards are linked with targets. So in the UK, across the whole of the UK, we have targets for how quickly you will be seen in emergency rooms, and that's 4 hours. We also have targets which relate to, we have a commitment to deliver treatment 18 weeks after you've been referred. So we have national targets which are set by our government. Underpinning our work, we have a real commitment to quality assurance. So we have developed in Scotland quality performance indicators for cancers, for general cancer, specific tumour sites. And we have many, many indicators, quality performance indicators for cancer, because cancer is one of Scotland's biggest killers. And not only have we collected all these indicators and all this data, but what we do is we peer review each other's work. So Scotland is divided into 3 regions for cancer services, and each region looks at the other region's work. So there's a quality assurance programme behind that, and it's peer reviewed. So we don't just have indicators, we have a robust system to look at what do those indicators mean. But one of the key aspects of the organisation I work with is we have an improvement function. So where we see services not performing well, there's a whole suite of responses, and that service would be expected to improve. And that's a very, very different thing that Scotland has. We are unaware anywhere else in the world which has an organisation that develops standards, which is what my team does, quality assures those standards, and then puts in improvement methodology to help that standard, that service rather, get better. So we have a cycle of improvement. We report to our own government, and we report everything publicly. So all our data is available online and in reports. We also support boards and services to identify how they can demonstrate they are meeting those indicators. And I've got some copies. These are some standards we recently developed for pressure ulcers. And in the standards, we have an evidence base. We have a rationale of why that standard is really important, what that indicator is looking at, and crucially for us, what does that mean for the organisation? What does this indicator mean for the staff? And what does it mean for the person receiving care? And then we have a whole range of ways that that organisation can demonstrate compliance with that indicator. And all of this is publicly available. So I just want to go through some aspects of data collection to public reporting. This is based on our experience. We have had our fingers burned many times developing indicators. So I'm coming from you with a very much, this is what's worked for us, but recognition things haven't worked, because I think that's one way that we learn when we put our hands up and say, this was quite hard. So some of this is heartfelt, some of this was worked through with some difficulty, and I share it with you so that it minimises some of your difficulties. What do we collect data on? And this is based predominantly on what we do in the UK. We cover virtually every single sector where healthcare is received. In somebody's home, in the emergency room, in the family doctor, whether it's a speech and language therapist, every setting we collect data on. But we recognise that not everybody does, and there are challenges around that, and I'll come on to those challenges in a minute. It is also possible to collect data, not just from the public sector, and the public sector often is an easier platform to collect data on, but also the private sector. The impetus as why you may be developing indicators for the private sector may be more financial, but there will also be clinical and safety reasons for that. We collect data on the general population, so we have general population screening data, but we also collect data around specific conditions, for example, diabetic retinopathy, and specific services, for example, services for older people. We have a huge plethora of routine data that we collect when patients come in, and that may be to do with attendance, that may be to do with treatment, but we also collect data on when people do not attend, and that is a significant problem in the NHS where people do not attend for appointments. I mentioned earlier we collect electronic data, and even the general practitioners and the surgeons will complete data collection. So it's not necessarily a specific admin person that does it. And a lot of that electronic data is routine. Everybody in the NHS in the UK has a unique identification number. And that means that we are able very quickly, when they come in, to submit data on them, which goes to central data sources. I mentioned earlier that we have observational data, but we also look at people's experiences, and those are equally as important. One of the things that we look at is the frequency that we collect data. And sometimes we vary the frequency depending on the particular condition that we're looking at. And sometimes we vary the frequency because actually the spotlight of the media has identified a problem. So we had significant problems in the UK around healthcare-acquired infection. And it was all over the press, the cleanliness of our hospitals. And there were some horrendous horror stories about unclean wards. And we increased the frequency of how we collected that data and what data we collected so that we could respond and demonstrate what we were doing as an action to improve the state of our hospitals. We have rate-based data, as you will do, but we also have sentinel data, and I know there's been a lot of discussion this morning about adverse events. We publish a huge range. We publish mortality, we publish adverse events. We also have systems in place where members of staff can whistleblow, and that's investigated, and anonymous reports, confidential reports of that, are also published. So data is varied. It's varied in many ways, but that leads to some complexities and challenges when we analyse it. So, one of my key roles is to develop standards and indicators for the UK. Some of our standards and indicators, for example, our indicators on abdominal aortic aneurysms, have been implemented by the the NHS England. So we have a key role in developing indicators. And I just wanted to share with you our learning. We have to be absolutely on the money around clarity of definitions, and we have to agree those definitions. We also have to make sure that what we are measuring is the right thing to measure, and it is done sensitively and robustly, so that we detect as few false positives as possible, but also as few false negatives as possible. And that's a real key, because we do not want our systems to have the bias that false positives and false negatives. But also we have to be mindful that if we are using data on false positives and false negatives, what impact that may have on the patients themselves. Of course, we have to make sure the indicators are reliable and that they are valid, especially where we wish to make national comparisons or where we wish to make regional comparisons. We have to make sure that what we are collecting is what we intended to collect and is replicable. Because it has to be useful if we wish to make comparisons. And one of the challenges we've had is that the way that services are delivered in Scotland, which is on a geographical basis, there are different interpretations. So when we go to look at pregnancy and newborn screening indicators, we found very early on that the reporting period was not the same. So the variation was not variation in provision of service, it was variation in the way we collected indicators about those services. And that was a real hard learn for us. As I mentioned, all our indicators are evidence-based. So we work very closely with our knowledge management teams within our organisations to make sure that when we say that this is the target, we are absolutely clear there's an evidence base for that, because otherwise, particularly in the world that we live in, which is financially constrained, people won't comply. Okay, so we report virtually everything. I mentioned the caveat that we don't report where a patient could be identified. Where we do report, we are very mindful of the audience. So some of the data that we present to our government may be presented in a different way from the data we present to patients. We are also very mindful of the language with which we present, and we're also very mindful that the press will very easily get hold of our data. So we have to make sure that we provide a context that helps explain and that helps people to understand what it is we're reporting on, because very easily we have had data where it has been extrapolated by the media and we are left with a situation which actually was about misinterpretation. So much of the data that we have, particularly if there are outliers, we have disclaimers and we have caveats. And it's really important when you do publish as much as we do that you have real clarity around what does this data mean. We are a very small country. We are only 5 million. And in some of our health boards, we have very, very few people, particularly when we look at rare diseases. So what we do is we are very mindful of confidentiality, and that's all protected within legislation. And so we aggregate data. Sometimes we present things as a dashboard, and patients find that really muddling. And so what we're, again, going back to the audience, we have to really think about what is the best way to represent this. Because what we don't want to do is report on data that nobody can actually understand, because that then makes that meaningless. So I mentioned earlier about the importance of analysis. What do we do about missing data? Sometimes we find that missing data isn't actually missing data, it's incorrectly entered data, or the data is based on wrong coding. So what are the quality assurance processes around your data collection systems? How do we interrogate those? But it's also interesting we look at risk adjustments, for example, socioeconomic, complex diseases. How do we know that the data that we're presenting is an accurate reflection? Because an indicator is only that. It only indicates, it doesn't tell us. So we make some assumptions based on those indicators. But we have to make sure the data is as clean as possible. And I've mentioned false positives and false negatives already. Because in the UK everybody has a unique patient identification number, we are able to make data linkages across all our sectors, but also increasingly across social care as well. So we can tell a patient's journey, we can look at their complex needs, we can understand why it is that postpartum women with congenital heart disease aren't doing very well, because we have data linkages. And we have an intelligence platform that enables us to do that. But there are challenges when we work across multi-agencies around firewalling, around encryption, around confidentiality. And we recognise these. And we don't know all the answers for these. And the NHS in England have spent millions and millions and millions and millions of pounds trying to build a system that supports data collection. And they're not doing very well. And I can understand why. Okay, to talk a bit about legislation. So, is it mandatory? If it's not mandatory, you're far less likely to get organisations and services to comply. But with mandatory comes a whole host of complex challenges. And often, if something is mandated by a government, it may be for a different reason than what the clinicians would wish. We're very clear around the expectations and purpose of data collection and disclosure. So when we come to, and we wouldn't use the term enforce, but when we come to enforce compliance, we have to be very, very clear why. Why is it that people are expected to complete the indicators? Very clear why we expect people to take part in improvement. And again, with reporting, is it mandatory that it's reported? If it's not mandatory to collect indicators, then it probably isn't going to be mandatory to publish. So it's not just the publication that we need to look at, it's also why we're publishing and where is that set? Is that set in statute? But also non-compliance. So what do we do where services don't complete the data? What do we do about that? Do we support them? Or do we in some way penalise? Similarly with poor performance. Particularly when performance-related pay, this is a real challenge. In the UK, we don't have performance-related pay. But where boards and services are submitting poor quality data, we still would go in and investigate, but it is not the same level of sanctions as in other countries. But also there may be legislation required around transparency. For example, in the UK, particularly in Scotland, there is a requirement for every board and for the clinical governance structures to include patients. And as soon as you have a patient on the clinical governance structure, your transparency will increase. Just very briefly about the required resources. And there is a huge requirement for resources when you're developing indicators, when you're looking at quality improvement. This is what we have found. We need people with experience and evidence in analytical services, in IT frameworks, in data entry, but also for those that scrutinise or quality assure. When you analyse the data, we have found that we have to have analytical services involved in that. But we also use those that inspect or quality assure the services, particularly where there's been observational. So it's a huge range of services and personnel, and that the training and the qualifications for those require us to be really committed. We have improvement advisors to support implementation. And the final bullet point here around evaluation, I would urge you, when you're developing indicators, to evaluate the efficacy of the indicator, to evaluate the efficacy of what the indicator is telling you. Is it actually telling you what you want to know? And to ensure it remains fit for purpose and value for money. Financial resources are huge. Nobody in the current global climate can walk away from the real issue of finances. But for me, I would also urge you to think about the values, the cultures and the behaviours. We have a culture in the UK, a commitment to indicators. There is an expectation that every person who works in the NHS will be involved in some level of data collection. And that requires a change in culture and behaviours. We also have we have a no-blame culture. So if we see a service's poor performance, there is a no-blame culture. The culture is more around supporting that service to improve. And I would urge anybody who's interested to look up human factors. The human factors around improvement is a fascinating world, and it's all about the values and behaviours. And without that value and behaviour change, there will be no buy-in, and there is no amount of mandatory requirement will be effective until you have buy-in. I would also say that you need to recognise the short, medium and long-term goals. Brazil is at the start, perhaps, of its indicator journey. Think about what you can do now and think about where you want to be and how you're going to get there, because it is a journey worth making, but it's not without its commitment in terms of financial, personnel, IT and cultural shifts. Finally, how is this indicator going to enhance the performance of your organisation or the provider? What do you hope it will do? How will it benefit the system? How will it benefit staff? And I mentioned in here, we actually explicitly include that so that we're upfront. How do we think it's going to enhance that performance? I just briefly want to raise the flag for the Scottish Patient Safety Programme, which is world class. It looks at indicators across a range of services, and it works to improve those services, and we have astonishing results. Mortality in maternity services dropped by 14% by looking at our indicators and applying improvement. Sepsis dropped by 20% from the implementation of the sepsis bundle, which was developed from looking at our sepsis indicators. Excuse my pronunciation, but mucho obrigadas.